In this series of 4 short talks, we'll be looking at renal homeostasis. We're not really going to go into the details of renal physiology or the function of the nephron, but rather we'll be taking an overview of the role of the kidney in maintaining homeostasis. So we always start with a case, and this one is a 64-year-old diabetic with dehydration, vomiting and lethargy, a high blood sugar and acidosis, metabolic acidosis. And over the course of these 4 talks, we're going to think about the role of the kidney in achieving homeostasis in this patient, consider what homeostasis actually is, and the general roles of the kidney in maintaining homeostasis. At the end of each talk, we will come back to this case and have a look at it. So pause the video and see if you can come up with your own definition of homeostasis and the ways in which the kidney might be involved in maintaining homeostasis. Here's a fairly straightforward definition of homeostasis. It is a self-regulating process by which a living organism can maintain internal stability while adjusting to changing external conditions. And the kidney plays a part in electrolyte balance, fluid balance, osmolality, acid-base balance, some endocrine functions, and maintenance of blood pressure, so cardiovascular stability as well. In this series of talks, we're going to focus on electrolyte balance, fluid and osmolality, homeostasis, acid-base balance, and a little bit on carbohydrate homeostasis or glucose homeostasis. So here's another patient, a 68-year-old male patient who presents to the emergency department with lethargy, dehydration, and is on furosemide for heart failure. And his initial blood tests show hypokalemia. So what we want to think about what fluid and electrolyte abnormalities are likely in this patient, how the kidney would respond to these, particularly in relation to salt and water homeostasis and potassium homeostasis. And also, just to think about what other homeostatic mechanisms outside of the kidney might be involved in this case. So let's just look at salt or sodium, potassium and water balance. And we'll start with sodium and water. These tend to go hand in hand. So there are really 3 big mechanisms for maintaining sodium and water balance. And the first is simply the physiological function of the kidney. So let's take an example. In a patient who is, like our patient, dehydrated, renal blood flow is reduced, and therefore glomerular filtration would be reduced, leading to a longer transit time through the tubules, the renal tubules, and an increased opportunity for salt and water reabsorption. So the balance of low GFR, which decreases the amount of glomerular filtrate, and a prolonged transit time in the tubules, which increases reabsorption or the opportunity for reabsorption, means that mechanically the physiology of the kidney is built in such a way to maintain, to preserve and reduce the loss of salt and water in the hypovolemic patient. Of course, these mechanisms are further enhanced by the actions of the renin-angiotensin-aldosterone system and ADH. The renin-angiotensin-aldosterone system responds to both hypovolemia and low sodium concentrations through the juxtaglomerular apparatus by stimulating the production of renin, the conversion of angiotensin and angiotensinogen to angiotensin, and then ultimately to angiotensin 2 through the ACE enzyme found in both the lung and the kidney, and finally the secretion of aldosterone. Aldosterone promotes the absorption of sodium from the distal tubule and the secretion of potassium. So through this mechanism, we maintain or increase salt and water reabsorption in the kidney. The other mechanism is the secretion of antidiuretic hormone from the posterior pituitary, and this responds to changes in serum osmolality. So if there is an increase in serum osmolality, the serum is becoming more concentrated. For example, when we get dehydrated, ADH is produced from the posterior pituitary, and this has an effect of increasing free water absorption in the thick ascending loop of the limb of Henle, and the collecting ducts. In this way, we increase water absorption from those parts of the tubules, and therefore that would reduce osmolality but also increase fluid volume. So that's salt and water balance. What about potassium balance? Well, potassium homeostasis is mostly dependent on aldosterone. So aldosterone increases the absorption of sodium in the distal tubule at the expense of potassium. And aldosterone secretion reacts both to low sodium levels and low blood pressure through the renin-angiotensin system, but also to low levels of potassium. Low levels of potassium suppress the secretion of aldosterone. There are other mechanisms by which potassium reabsorption is controlled. In any situation where there's a high load of potassium presented to the distal tubule, the exchange of high load of sodium presented to the distal tubule, there's an exchange of sodium for potassium and an increased loss of potassium at the distal tubule. And in situations of acidosis, the competition between hydrogen ions and potassium ions at the distal tubule for exchange of sodium which is being reabsorbed means that less potassium is excreted in an acidemic environment, because the hydrogen ions are exchanged for sodium in the distal tubule in preference to the potassium in that situation. However, that is balanced in the long term by the effects of aldosterone. Acidosis seems to stimulate the activity and production of aldosterone and increases the loss of potassium in patients with long-term acidosis. So the acute situation, acidosis inhibits the loss of potassium, and in a chronic situation it may enhance it. Bear in mind that there are other mechanisms by which acid-base balance affects potassium significantly through the shift of potassium from the intracellular to the extracellular compartment. So acidemia promotes high PER kalemia. So quickly, let's have a look at this patient. This patient will be hypovolemic because of dehydration. Well, we know it looks as if this is diabetic ketoacidosis. The acidosis would have caused high PER kalemia, and the patient is acidotic. In this environment, we will have an increase in sodium reabsorption, and although the acidosis will reduce the loss of potassium in the kidney, the high level of sodium being reabsorbed in the distal tubule will promote loss of potassium, and the shift of potassium from the intracellular to extracellular compartment also means that there's more potassium in the extracellular compartment, more potassium being presented to the distal tubule to be lost in exchange for sodium. So these patients have a high PER kalemia, but may have a loss of total body potassium. If you have any questions, these can be addressed in class. So this first lecture looked at sodium, potassium, and fluid balance. Subsequent lectures will look at calcium, magnesium and phosphate, acid-base balance, and carbohydrate homeostasis. Thank you.